discuss the respiratory tract infection. So if you have joined us, please come and say and drop a hi in the chat box. I would be very happy to meet you, greet you, say hi, hello, good evening. Good evening, guys. So, आज respiratory tract infections में, as the rule remains, we are only going to cover the topics not covered in 2025 FARRE. So, homework for today, right now at the beginning of the lecture only, I'm giving you the homework, and that is to go and watch this thing. Go and watch this. This is the FARRE 2025 respiratory tract infections. And in this lecture, I have covered all causes of bacterial pharyngitis, including streptococcus as well as diphtheria. Hi, good evening, good evening. Atypical pneumonia has been covered there, in which we have done MLC, right? Medico-legal report? No. We have done Mycoplasma, Legionella and Chlamydia. All right, good evening, good evening. Atypical pneumonia has been done there. Lobar pneumonia will be done today, okay? Then Mycobacterium TB as well as non-tubercular mycobacteria covered over there. Influenza, COVID-19, Epstein-Barr virus, all viruses covered over there. All fungi, including PCP, Aspergillosis and Zygomycetes, including the mucorales. All high yield topics, major topics covered in this particular video. Today, we are going to cover lobar pneumonia, pertussis, the paramyxoviruses. Okay, so amongst the myxoviridae, you have two types of viruses, orthomyxoviridae and paramyxoviridae. Who is orthomyxoviridae? Influenza virus is your orthomyxoviridae, which has been covered in this particular video. Whereas the remaining paramyxoviridae we are going to cover today, okay? And then the lung fluke, which is Paragonimiasis westermani, right? So till the end of the lecture, we are going to wait for that jingle. Hawa se halki paragon, yes, and then that will finish all the parasites, all right? Not just lung fluke, we will also discuss tropical pulmonary eosinophilia along with it, which is also called as occult filariasis. Yes, occult filariasis. That will also be discussed along with it. So these are the topics that we're going to discuss today. Of course, it's going to be in a handwritten format, right? The way to present in the exam switches, and we are going to start, right? So when we talk about lobar pneumonia, what is the difference between atypical and lobar pneumonia? So basically, you know, if you have this diagram of the lungs and you have these alveoli in the bronchial tree, if the alveolus is filled with pus, then that becomes your lobar pneumonia, okay? It involves the entire lobes of the lung. Hi, good evening. If it involves the spaces, the space alongside the alveolus, which is completely filled, the interstitial space is filled, that is interstitial pneumonia or atypical pneumonia. Interstitial or atypical pneumonia has been covered in the video of 2025 where we have discussed MLC, Mycoplasma, Legionella and Chlamydia. Okay, so today we are discussing lobar pneumonia, and lobar pneumonia is also majorly contributed by the bacteria. Okay, bacteria. चलो जी, सो बैक्टीरिया में हम बात करेंगे. जब हम लोबार निमोनिया को डिफाइन करेंगे तो कैसे डिफाइन करेंगे? इन्फ्लेमेटरी एक्सुडेट्स कहाँ है? विद इन द इंट्रा-एल्वेओलर स्पेसेस, कंसोलिडेशन. Basically, you will see consolidation of the large and continuous area of the lobe. So, if this is a normal lung, this is the normal alveoli, then this entire lobe is going to be consolidated. You know what is consolidation? It is a solidification of that area. Therefore, you can examine it on physical examination, general physical examination, which you read in medicine, right? So, when you have what am I getting? Can you please help me how to study? All right, Ravi. So for your help, we are going to soon launch the, bridge course, and of course the first year faculty can help you with that. This lecture is intended for the second year students, so let's focus on second year. All right. So like I was saying, what question will you get? Usually, mostly, lobar pneumonia, how will it come in the exam? It will come as a long clinical question. ठीक है? Long clinical case आएगा. Or in very rare circumstances, if they don't want to give clinical case, then they can give a long essay type question. Very unlikely that lobar pneumonia will be asked as a short note, okay? What they can ask as a short note is the specific agents. So, you know the etiology of lobar pneumonia is all of these bacteria. If they want to specifically ask you about, let's say, pneumococcal pneumonia, then okay, maybe it can be asked as a short note. Otherwise, it will always come as a long essay type or long clinical case based question. So what case you will get, what will be the presentation? They will of course say that the patient will present with all of these clinical features, right? Okay, where have I mentioned the clinical features? All right, so the patient will present with fever, patient will present with respiratory distress, patient will present with production of sputum, patient will present with, can also present with, complications like seizures. So, क्या आएगा आपके पास? Fever, night sweats, cough, and sputum production. This will be your markers, okay? This is going to be there, and also they might give the little hint that on examination, there is reduced auscultatory sounds in the chest, okay? All of that will point towards lobar pneumonia. So what are etiology? They can also mention that we can see gram-positive cocci encapsulated. They can give you a hint. So from that, you have to reach either of these etiologies, right? So I always tell my students that the same bacteria which cause meningitis are the same guys which also cause pneumonias. And bacterial meningitis, how have we learnt it? That brain is inside a skull, okay, brain is inside a covering. So all these bacteria who cause infection of the brain, they also are in a covering. So you have strep pneumoniae capsulated has a cover, H. influenzae capsulated has a cover, Neisseria meningitidis capsulated has a cover. Two out of these, strep pneumoniae and H. influenzae are, okay, thank you so much, Javed. Strep pneumoniae and H. influenzae are also major causes of lobar pneumonia. So you see, lobar pneumonia can be caused by the entire spectrum of bacteria that you read. It can be caused by gram-positive diplococci, gram-negative cocobacilli, gram-positive cocci, and gram-negative bacilli. So you can have your GPCs, you can have your GNBs. Both can infect, okay? So if it's a GPC and it clusters, it is Staph aureus. If it's a GPC in pair with a capsule, it is Streptococcus pneumoniae. If it's a gram-negative cocobacilli, short gram-negative bacilli with a capsule, it is H. influenzae. And other gram-negative bacteria such as Klebsiella pneumoniae, again which is capsulated, and Pseudomonas species. Pseudomonas ka bhi some strains are capsulated, okay? Oh, this is a slow speed only. All right, chaliye. ठीक है, strep pneumoniae, H. influenzae, Staph aureus, and Klebsiella pneumoniae as well as Pseudomonas. These are the agents of lobar pneumonia. चलो जी, next पे आते हैं. Then you have to write about, might be the question will point towards strep pneumoniae specifically. So what all features of strep pneumoniae do you know of? Strep pneumoniae is a gram-positive diplococci in pairs and under a capsule. So I always tell my students how to remember strep pneumoniae, like a couple under the blanket, Netflix and chilling, okay? So what is happening here? Netflix and chilling is happening. So it's a capsulated, lanceolate-shaped gram-positive diplococci, also called as flame-shaped lanceolate. Basically it's gram-positive diplococci, so GPC in pair with the lanceolate or the flame-shaped appearance along with the capsule. Okay? Capsule is the most critical virulence factor. So now you have to write the virulence factors. So you have to factor in the capsule, you have to factor in the cell wall, and you have to factor in all the enzymes which is releases. That is the dictum for all bacteria. So even for strep pneumoniae, we will factor in the capsule. Yes, it is capsulated, and always whenever a capsule is present, my students would know capsule makes the bacteria tasteless, bad tasting. So your phagocytes cannot come and eat it, okay? So capsule is going to inhibit phagocytosis of strep pneumoniae also. Then what are the other factors? Cell wall. Cell wall contains the C polysaccharide, that also prevents it. Then surface proteins are there, important surface proteins. You need not learn all the full forms. You can just remember PSPA, PSPC and PSAA, okay? What is PSAA? It is pneumococcus surface adhesin, okay? Pneumococcus surface adhesin. So it will help in adhesion to the surface, it will help in adhesion to the lungs, okay? Then toxins which are released or enzymes which are released. So autolysin is an important enzyme which is released by the bacteria, and this autolysin enzyme is what we keep detecting in the lab diagnosis also. So right from this virulence factor, you understand what must be my strategy for lab diagnosis. What are the two most important virulence factors that you are seeing over here? They are the capsule and this autolysin toxin. Okay, so of course in lab diagnosis, these are the two things that I'm going to majorly focus on. Number one, I will detect autolysin production somehow. So what is autolysin going to do? Autolysin is going to kill the bacteria itself. So how will I check that? I will check that by bile solubility, and I will check that by the carom coin colonies. That is the reason, because of this autolysin, they are producing the carom coin colonies and the bile solubility. How do I detect the capsule? Capsule can be detected by Quelling reaction. So I will do the Quelling or swelling. Okay, Quelling leads to swelling or swelling reaction. Then capsule can also be tested as an latex agglutination test, right? So I can directly take the sample of the patient, do latex agglutination test. These are the main things that I will see under the lab diagnosis. Then there is a very special antibiotic susceptibility, which is used as an identification and not AST testing. ठीक है ना? So with this only I have a flow of what lab diagnosis I'm going to write. All right. So what is strep pneumoniae? It's a binocular shaped or a gram-positive diplococci, which is flame shaped or lanceolate shaped with a capsule. Most important virulence factor is the capsule, the C polysaccharide cell wall, and the autolysin enzyme, which is released by it. Then what are the clinical features? So we can always remember that MOPS is our mnemonic to remember all the clinical features of strep pneumoniae. Right. So why does it spread? This is very, very important to understand about strep pneumoniae, that it commonly colonizes the nasopharynx. Okay. And that is how it spreads, and that is how it causes the disease. So in more than 2 years old children, more than 2 years old children and adults, the strep pneumoniae normally colonizes the nasopharynx. Now, it might not be causing the disease at that point of time, but strep pneumoniae being present in the nasopharynx, it becomes very easy for the bacteria to go down and cause the lobar pneumonia. So what is the most important risk factor associated? Don't you think extremes of age is going to be a risk factor? If a person is extremes of age, then he is going to succumb to the infection by this colonizer. Secondly, overcrowding, where there is not enough ventilation, that is going to become a risk factor. And viral upper respiratory tract infections, that is a common risk factor for all respiratory diseases, what I just spoke. Every respiratory illness, common risk factors are extremes of age, overcrowding, and any viral upper respiratory tract illness. Why? Because when your body is already fighting a virus, the immunity is compromised or busy fighting the virus. So when a bacteria comes, it is not able to fight it that well. So that makes the patient succumb to a secondary bacterial infection also. All right. So what are the diseases? Like I said, we have to remember MOPS. M is meningitis, like I said. Then P is pneumonia, like I said. The two most important diseases which is caused by Streptococcus pneumoniae. If the examiner has to ask you Streptococcus pneumoniae in university exam, they will either give you a case of pneumonia or they will give you a case of bacterial meningitis. Simple as that, okay? It can also cause otitis media, because any infection that can, anything that can infect the respiratory tract can always pass to your ear and can always cause otitis media, always, any agent, all right? And then, of course, sinusitis is not far behind. If respiratory tract is here, sinuses are also here. So what does strep pneumoniae cause? MOPS, meningitis, otitis media, pneumonia, and sinusitis. These are the major important diseases spread by strep pneumoniae. Then for lab diagnosis, what will you collect? Obviously, depending upon the disease. So you will collect the sputum of the sample. Why? Because sputum is a lower respiratory tract specimen and pneumonia is a lower respiratory tract infection. What is pneumonia? Pneumonia is an LRTI. So you are basically involving the lower respiratory tract. You are involving the lobes of the lung. Okay. So sputum is a lower respiratory tract specimen. What other LRT specimen can you take? You can take BAL, bronchoalveolar lavage in the patient, okay, or a mini BAL, depending upon the condition of the patient. Then you can also take the blood for serology to detect antibodies. CSF can be taken in case it is causing meningitis, and pleural fluid if it has led to extrapulmonary complications. Culture can be done on enriched media. Yes, it's a fastidious guy. It needs enriched media. So either blood agar or chocolate agar is what is required, and it loves 5% CO2. This is what is important. So you will use either blood agar or chocolate agar, and you will use it in 5% CO2 environment at 37 degrees Celsius. And next day I will see that it is showing me alpha hemolytic carom coin or draftsman colonies, where there is a depressed center due to what? Due to autolysis. Yes. So have you ever seen the carom coin? It looks like this. This is one disc of the carom, and then in the center there is like this depression. So this is what a carom coin looks like, and this is exactly what the colonies of strep pneumoniae also look like. Why is there is this central dip or dip in the center? Because of this autolysin which it is producing. So the colony is growing, bacteria releases autolysin, starts digesting the center of its own colony. Okay, so you see the classical, and these are also alpha hemolytic. So they will also show me this greenish zone of hemolysis, greenish zone of partial hemolysis. So these are the carom coin colonies. So you can easily draw this diagram also, right? You will just simply write carom coin appearance with the alpha hemolysis, with alpha hemolysis, right? Carom coin appearance plus alpha hemolysis on blood agar or chocolate agar. Then, like I said, what biochemical tests? Wahi, the same biochemical tests the same properties that I was seeing in virulence factors, same things I will test for lab diagnosis. So which biochemical tests am I going to do? I'm going to do bile solubility. Of course, in the presence of bile salts, the bacteria starts releasing autolysin. So it dissolves. So bile solubility is positive. Then Quelling or swelling. This is Neufeld reaction. So Quelling rhymes with swelling. So there is swelling of the capsule. So basically there are 2 gram-positive cocci sitting under a single blanket. I put some anti-sera on top. In response to this anti-sera, the capsule, it swells and becomes more refractile. That I am able to see under the Quelling reaction. So you can simply draw these two. You can, just draw 2 gram-positive diplococci sitting like this. Okay, flame shaped, and you can say that, okay, they have this nicely tight capsule around. And then when I add antitoxin, what have I done? I have added antitoxin on top. So after adding antitoxin, I can see this refractile or swollen capsule of the two, right? The bacteria are still over here, but the capsule is getting swollen. That is Quelling reaction. Next, what will you detect? You will do optochin sensitivity. This is very, very specific for pneumococcus, where it is optochin sensitive, right? And you have to give vaccines. Another thing that you can write is inulin fermentation. That is point number 4. It is an inulin fermenter. Inulin is just a sugar, so inulin fermentation positivity can also be seen. But majorly you have to see optochin sensitivity, bile solubility, and Quelling reaction. Finally, for prevention, you can give vaccines. And you know that the capsule is the most important thing about this guy. So even in the capsule, what am I going to give? I am going to give the capsular antigen. So pneumococcus has a capsule. And you know that as a rule, all bacteria have the polysaccharide capsules. Right? All capsules are made up of polysaccharide, except at gym buddies. My students would know which 2 gym buddies I'm talking about who need a protein. So also, just like everybody else, strep pneumonia also has a polysaccharide capsule. I am giving it in the form of vaccine. Can I call it pneumococcal polysaccharide vaccine, which is PPSV? And depending upon this capsular antigen, there are many, many serotypes. So I have taken and added 23 serotypes into this vaccine. So it's a pneumococcal polysaccharide vaccine with 23 serotypes. So that's PPSV 23. Okay, PPSV 23. Then you have pneumococcal conjugate vaccine 13. This is a conjugated vaccine. And those of you who have attended the immunology lecture, you have clear-cut understanding of the T-dependent and T-independent antigens. Yes, you realize that when I take a T-independent antigen and add a protein to it, it becomes T-dependent and it becomes an adjuvant and it becomes a better immunogen, right? So that is what I have done. This capsule is always a T independent guy, okay? It will give a bad immune response. So we will need to keep giving booster doses. That is why with PPSV, you need to keep giving frequent boosters. But if you add a protein, if you conjugate it with a protein and form the PCV vaccine, then it is much more immunogenic and needs much less booster doses. So 2 important vaccines of pneumococcus is PCV 13, which is a conjugate vaccine, pneumococcal conjugate vaccine, and PPSV 23, which is pneumococcal polysaccharide vaccine. Both of them are actually your capsular. Both of them are capsular vaccines because capsule is the most important, is the most important feature of strep pneumoniae. All right. So that ends strep pneumoniae. Now you have H. influenzae. I always tell my students, ask yourself these 3 questions whenever you're reading a topic. Can I make at least 3 diagrams from this topic? So strep pneumoniae, can you make at least 3 diagrams? Yes, you can make 3 diagrams. You can make the quelling reaction diagram. You can make the carom coin colonies, and you can very well make the morphology of the bacterium. Can I make a differences table? Yes, you can make a differences table. You can talk about lobar and interstitial pneumonias. Can I make a flow diagram? Yes, you can easily make a flow diagram of the pathogenesis, even though it is not involved here, but you know all the things which is required for pathogenesis. Will enter through the respiratory route will adhere using the PSA adhescents, and then it will invade inside and cause lobar pneumonia. You know all of it. So you can easily make a flow chart, a differences table, and 3 diagrams from this Streptococcus pneumoniae. Right? Then the same way we have to understand, can we make 3 diagrams, 1 flowchart, 1 comparison table from H. influenzae topic? Can we? Yes. So 2 though I have drawn for you only. And while these are AI generated a little fancy diagrams or inaccurate diagrams, these at the bottom I have drawn just to show you that you can also very easily make them in the exam. So before we move on to the diagrams, let's first understand about H. influenzae. What is H. influenzae? It is also khopdi wala bacteria, meaning it is also the bacteria inside a skull. So it is also capsulated, right? This is not influenza virus. Okay, influenza virus is separate. H. influenzae is a bacteria. All right. H. influenzae is a pleomorphic gram-negative cocobacilli which is oxidase positive. Okay. We all have the mnemonic of V pinch. When we pinch the cheeks, they turn purple. So oxidase positive are the V pinch organisms. However, my students would know the mnemonic vape bench. Okay. So in in all of them, you have H, which is H. pylori as well as H. influenzae, right? And it is factor loving. This is the most important point about it. H. influenzae is fastidious. It is also very much fastidious. So it can only and only grow in chocolate agar. Advise that, because chocolate agar, how is chocolate agar made? I take blood agar and I heat it up. So the blood releases factor X and factor V. So this factor X and factor V is very, very important for the growth of H. influenzae. Right? So I have to prove it in the lab. How can I prove it in the lab? I can prove it by doing this factor X and V requirement test. So I will come on to it just a minute later. So basically on chocolate agar, it is getting factor X and V. Factor X is hemin and factor V is NAD, which are both present in chocolate agar. Therefore, it grows over there. Again, virulence factors has to be the polysaccharide capsule. Now, so you know, since childhood, you have all been taking the pentavalent vaccine. What does pentavalent have? D, P, T, hepatitis B and Hib. What is Hib? H. influenza serotype B. Now, there are many serotypes of H. influenzae also, but which is the most important serotype? It is serotype B, because this serotype B is made up of the PRP capsule, the polyribitol phosphate capsule. Polyribitol phosphate. Even if you don't remember the full form, just write PRP. And this PRP capsule makes it very different from all other strains of H. influenzae. And this PRP capsule wala H. influenzae serotype B is associated with the most severe form of disease, the most severe form of meningitis, most severe form of pneumonias. That is why under the national immunization schedule, we have only included the serotype B of H. influenzae. Okay? Now, there are some outer membrane proteins, there are pili, and there are the IgA1 proteases. Whenever there are IgA1 proteases produced by any bacterium, it becomes very, very pathogenic, because to think anything which is getting transmitted through the respiratory or the fecal-oral route, the first antibody which is going to come is the mucosal antibody, right, which is that IgA. And if the bacteria produces an enzyme which will cleave this IgA antibody, then it will get free path to go deeper inside the body. So this H. influenzae is also producing IgA protease, which is cleaving the IgA antibodies, which are coming as the first line of defense right in the mucosal surface, and it is cleaving it and going deeper and causing the disease. Right? So two most important virulence factors are your polysaccharide capsule and IgA1 protease. Right? Then you have like I said, Hib is the major cause of pneumonia and meningitis. Then it has some non-typable strains also. What are these non-typable strains? By mutations, they have lost their capsules. So we are not able to serotype them, but they also can lead to otitis media and etc. inside the patients. Now, lab diagnosis, what will we do? We will obviously detect the most significant features. For lab diagnosis, I will find out whether this guy needs factor X or factor V. For lab diagnosis, I will find out whether it has a capsule or not. Okay. So, majorly what we do for lab diagnosis is detection of factor X and V. So, what have I done? I have taken the specimens, which is either sputum or CSF, and you know CSF should never be refrigerated, okay, because H. influenzae especially does not tolerate cold environments. So H. influenzae dies in the cold temperatures. H. influenzae dies at 4 degrees Celsius, okay. So the classical test which is done for diagnosis is called as the satellitism test. Satellitism test. So for lab diagnosis, I can show two things. By this, I am showing factor X and V requirement. I am showing factor X plus V requirement. And over here, I am showing satellitism. Satellitism. So how will you show it? So first of all, let's talk about factor X and V requirement. So I've taken an agar plate. Simply draw a yellow colored agar plate. I have put 3 discs on this agar plate. So this is disc 1, 2 and 3. On these 3 discs, there are certain different factors which are coated. So the first disc is coated with only factor X. Second disc is coated with only factor V. And the third disc is coated with both factor X plus V. Now this guy needs both. So it will not grow with only mere presence of factor X. It will not grow with mere presence of factor V. It needs both. So what will you show? You will show this hazy zone of growth around the disc with both factor X and V. And you will write at the bottom that here what can I see? I can see no growth around this. I can see no growth around this. But I can definitely see growth present around the one with both factor X and V. Alright, so this is one way to prove that in fact the gram-negative cocobacilli that I am looking at is a factor X and V producer, right? Then you will talk about satellitism. What is satellitism? It is very easy to understand. See, what do you understand by satellite? All of the planets in the solar system are satellites. Yes, why? Because there is a sun in the center and everything is rotating around and close by to the sun. So the sun pulls all of these planets because of its gravity. That is why the planets are orbiting around the sun. Similarly, who is the sun? The yellow colored bacterium. So the sun is yellow, the bacterium is yellow. Who was the golden yellow pigment producing guy? Staph aureus. So you will take a blood agar plate and right in the middle of the blood agar plate, you will streak a Staph aureus. So you can see the golden Staph aureus with its zone of beta hemolysis. You can see the golden beta hemolysis around the Staph aureus. Now you will take some H. influenzae and you will streak it perpendicular to this streak of Staph aureus. So you can see the golden streak of Staph aureus and you can see the white streaks of H. influenzae. They have been streaked perpendicular to Staph aureus. Now what will happen? The growth will happen majorly close to Staph aureus. So Staph aureus will pull these colonies like gravitational force of the sun. Okay. So you will see that maximum colonies of H. influenzae are formed close to the streak of Staph aureus. Maximum colonies or the biggest size colonies are right over here. Whereas as you move far away, you will see that there are very few colonies. And as you move further away, you stop seeing any colonies. Okay, so you can simply draw this and you can label it. You can say that here we can see that all colonies are growth near the streak of Staph aureus. And as you move away, you don't see any growth. Simply you will label it and you will let the examiner know that this is satellitism. The growth is closer to the streak of Staph aureus. Why? Because Staph aureus is releasing factor X and V. It is releasing factor X and V. Therefore, the colonies are only growing close to the streak of Staph aureus. I just told you why does it grow close to Staph aureus. Because Staph aureus is releasing your factor X and V. Okay. Therefore, and wherever there is X and V, it will go near that place. So either you put it on a disc, it will grow near that place, or you give it to it using a Staph aureus, or you give it to it using a chocolate agar. Whatever, however you're providing it factor X and V, that is where H. influenzae will grow. And this is what you will write in the lab diagnosis. 3 points you will write: chocolate agar, satellitism, and factor X and V requirement test. That's it. Okay. And please write and highlight the point of no refrigeration, of never refrigerating the samples of H. influenzae. Highlight it to gain marks. Of course, for prevention, we will give the vaccine, the HIV PRP capsular antigen containing pentavalent vaccine. Yes, DPT, Hep B and Hib, which is given as a part of the national immunization schedule. So, 2 most important diagrams made for H. influenzae also. So, we have done with 2 agents of lobar pneumonia. Then you have another guy with the name pneumoniae, which is Klebsiella pneumoniae. And you know Klebsiella pneumoniae is an enterobacterial. So without even thinking, for all enterobacterials, you can write 6 biochemical reactions. What are they? Catalase positive, oxidase negative, glucose fermenter, nitrate reducer. These are the 4 things that by rule all enterobacterials will produce. So Klebsiella ka biochemicals are very easy to write, right? So, okay, we will come on to that. First, let's see what is Klebsiella. It is enterobacterial, and we only read 2 lactose fermenter enterobacterials, E. coli and Klebsiella. So, Klebsiella is a lactose fermenting, non-motile, capsulated gram-negative bacteria belonging to the family Enterobacteriales. Belonging to the family Enterobacteriales. Yes. All right. Hallmark sign is the current jelly or brick red sputum, which is shown by Klebsiella pneumoniae. On culture, it shows me the highly mucoid, large convex colonies. Now, these mucoid colonies, when picked up with a loop, they stretch like a string of cheese. Yes. So, it also gives me the string test positive, wherein these mucoid large colonies stretch like a string of cheese when picked with a loop. Why do they do that? Because this capsule is very, very hygroscopic and it produces these large mucoid colonies. So it absorbs all the water and becomes large and mucoid. Therefore, when you pick it up, it stretches like mucus, okay, mucus or string of cheese. Then it is often multi-drug resistant, such as extended spectrum beta-lactamase production or carbapenemase production. So if you have to do identification of it, what will you see? You will see that on gram stain, I am seeing capsulated gram-negative bacteria. Capsulated gram-negative bacteria which are non-motile. Now, for the biochemical reactions, very, very easy. We will write all the reactions of enterobacterials. What are the reactions? Catalase. They are all catalase positive. They are all oxidase negative. Oxidase negative. Now, who will write in the chat box the only 2 exceptions to these 2 enterobacterials? It's a fun question, okay? Yes, all enterobacterials follow common rules. There are 2 outliers, and what are they? Okay. Then there is catalase positive, oxidase negative. All of them are nitrate reduction test positive. All of them are glucose fermentation positive. All of them. And then for Klebsiella especially, we have what? MVQ. We always read it together for E. coli and Klebsiella. E. coli MVQ is plus plus minus minus minus, and Klebsiella MVQ is minus minus plus plus plus. So indole negative, MR negative, VP positive, citrate positive, and urease positive. These are the biochemical reactions of Klebsiella. Done and done. Okay. चलो फिर बाकी GNBs और कौन से हो सकते हैं? Serratia marcescens. I always tell you that it has the word Mars in it, and Mars is the name of the red planet. So this gives me the red pigment production. That can also cause your pneumonias. And since it is making the red pigment production, it leads to something which is called as pseudohemoptysis. Pseudohemoptysis. Why do you think this is happening? Because it looks like the patient is coughing out blood in sputum, but it is actually just the red pigment of the bacteria which it is releasing in the form of red pigment. Okay. Chalo. Fir Pseudomonas aeruginosa can also cause it. What is Pseudomonas aeruginosa? It's a, no, yes, one exception is Shigella dysentery type 1. Excellent. And Shigella dysentery type 1 is what? It out of catalase and oxidase. Let me know that. Pseudomonas is not an enterobacterial. It's a non-fermenting GNB. It produces the green pigment. And Acinetobacter is also a nil fermenter, gram-negative bacteria. All right. So, what are your agents of lobar pneumonia? Strep pneumoniae. Remember the capsule. Remember Quellen reaction, bile solubility, and carom coin colonies. And optogen sensitivity. Then H. influenzae. Remember factor XNV and satellitism. Then you have Klebsiella pneumoniae. Remember the enterobacterial mucoid, large mucoid colonies with stringy colonies. Okay. Then you have Staph aureus can also cause it. Then you have Pseudomonas, Acinetobacter and Serratia marcescens. All the important bacteria done. So since you started answering, let me also tell you that yes, all enterobacterials follow the rule except two guys. One is Shigella dysentery type 1, which is catalase negative. Okay, it does not follow the catalase rule. And now very recently, based on genetic studies, Plesiomonas has also been included into enterobacterial family. Pseudomonas is not included. Only Plesiomonas is included. So that becomes oxidase positive. So all enterobacterials, which is Escherichia, Klebsiella, Serratia, Yersinia, Salmonella, Shigella, Edwardiella, Citrobacter, they are all what? Enterobacter. They are all going to be catalase positive, oxidase negative, except Shigella dysentery type 1, which is catalase negative, except Plesiomonas, which is oxidase positive. Rest all follow the rule. ठीक है, डन है, हो गया डन. नेक्स्ट चलते हैं और कौन से दूसरे कॉजेज हो सकते हैं. लाइक आई सेड, स्टाफ ऑरियस विच इज अ ग्राम पॉजिटिव कोकाइन क्लस्टर्स. इट कैन लीड टू वेंटिलेटर एसोसिएटेड pneumonias in the hospital settings. It will produce the golden yellow colonies on blood agar and the beta hemolysis. Staph aureus we have covered yesterday in the skin and soft tissue infections. Bacillus anthracis can also lead to pulmonary anthrax, which is a hemorrhagic pneumonia, in fact a type of bioterrorism agent. So it will lead to the medusa head colonies. Remember all of this. And Yersinia pestis can lead to pneumonic plague. That can also become a cause of pneumonia. So safety pin appearance on the Wason stain is seen with Yersinia pestis. Then you have Moraxella catarrhalis. Moraxella catarrhalis is a gram-negative coccus and it's a normal mouth commensal. Now we only keep reading Neisseria as a GNC. Yes, but Moraxella is also a GNC, is also a gram-negative coccus, okay, which is a part of the normal flora of the mouth. If it goes below to the lungs, it can also cause pneumonias. So it causes pneumonias and it gives me the hockey puck sign where the colonies can be pushed across the surface. So if I have an agar on which colonies are growing, if I just take a straight wire and push them, they will move across smoothly like a hockey puck, okay, like a hockey puck which is seen in ice hockey. So if you are asked to make a list, then don't just limit yourself to Klebsiella, H. influenzae, Strep pneumoniae, Pseudomonas, Acinetobacter. Also write Staph aureus, Moraxella catarrhalis, and as bioterrorism, pulmonary plague and anthrax. Okay. Short note, yes, definitely possible. Ashi, pneumonic plague and pulmonary anthrax, short note is definitely possible. Villanella, Neisseria, Moraxella are GNC. Excellent. From which Villanella is your anaerobe. Neisseria is a gonorrhea and meningitis and Moraxella is a commensal of the mouth. Very good. Nice. Chalo ji. Now we talk about whooping cough. Whooping cough is also called as Kali Khasi. Yes, pertussis. It is caused by Bordetella pertussis, which is also called as Bodegengu bacillus. How do my students remember this? That there was a Kali Gangu. So what is Kali Gangu? Kali Khasi, Bodegengu, Bordetella pertussis. So what will you ask Gangu? You will give a Bodegengu agar to Gangu. And you will ask Gangu, please cough on this agar. When Gangu will cough on the agar, she will shed pearls. So what do you see? You see the dissected pearl appearance on the agar plate. The dissected pearl or the mercury drop appearance. And the color of this agar is actually black. So the color of this agar is actually black because it is black khansi or kali khansi. So the Bodegengu agar is also black. So this is the mind map that we have about pertussis. Now we need to write everything about it. I have just told you the buzzwords right in the beginning. What is Bordetella pertussis or what is pertussis? It is the causative agent of whooping cough, जिसको काली खांसी बोलते हैं. It is a toxin mediated respiratory illness. So much so that the patient will have toxemia. Okay, toxemia. All right. It is characterized by the prolonged course. That is why it is also called as 100 days fever. It is also called as paroxysmal cough, right? It is also called as paroxysmal cough. Why is it called as paroxysmal cough? Because it happens in 3 phases. There is the first catarrhal phase, then there is a paroxysmal phase, and then there is a convalescent phase. What happens in paroxysmal phase? That the patient's culture negativity starts to come. Also, the person in between bouts of cough is absolutely normal. So there's a normal sitting person, starts coughing, does not stop for many, many hours. Turns totally cyanotic, turns totally apneic. So that is why it is called as kali khansi or paroxysmal cough. Morphology क्या है? Gram negative Coccobacillus है. Shows me the thumbprint appearance. Thumbprint appearance. So if you draw a gram stain picture, then simply draw these thumbprints. Okay. So you know how you should actually draw this. You should just make this gram stain ka field, and you should take and you should draw it like this. Just try to draw thumbprints. So this thumbprint appearance is seen on gram stain by Bordetella pertussis. क्या virulence factor है? Pertussis toxin is a major systemic toxin. It is a cytotoxin. It damages the respiratory epithelial cell, and it is also associated with the edema factor. Okay. So pertussis toxin has 3 important features: a binding site, a cytotoxin which destroys the cells, and an edema factor which causes edema of the respiratory epithelium. Adhesins are there which are going to help in adhesion, which are FHA, filamentous hemagglutinin, which is essential for the attachment of the bacterium. ठीक है? Virulence factors done. Then clinical phases: the catarrhal phase, the paroxysmal phase, and the convalescent phase. What is the catarrhal phase? It is the early stage where there is maximum infectivity, and it is the best time for doing the culture. Paroxysmal is violent coughing bouts followed by a whoop sound, and there is post-tussive vomiting. Usually cultures are negative, and this is the paroxysm. This is the paroxysm. That is why it is called as paroxysmal cough. Convalescent is the recovery period. Here the antibodies are going to be positive. Okay. Primarily it will affect whom? What is given as a national immunization schedule? DPT. DPT has P. So pertussis toxoid vaccine is given right in the childhood. So only the people with a history of unimmunization. Okay. Unimmunized child. This is going to be the word in the question that you will find. An unimmunized child. Okay. That is the major risk factor. Because of course, vaccine is available, which we give right in the childhood. Then you will collect nasopharyngeal swab, sputum, but throat swab is unacceptable. Throat swab is unacceptable because it can lead to gag reflex. It can lead to, if you can remember 2 more adhesins prawns, it's good for you. However, only this much is essential to write an exam. Since FARRE is supposed to be quick revision, of course, not everything is being discussed. चलिए जी, excellent. So unacceptable है क्या? Throat swab. Why? Because it is going to give a gag reflex to the patient, and patient might start having a coughing bout. Also, it is not found so up in the respiratory tract. At least you have to go up to the lower level, which is the nasopharyngeal swab, because pertussis involves the bronchial tree. It involves the laryngobronchial area. Therefore, it is a little lower in the respiratory tract. Transport media used is charcoal containing media called as Ames or Stewart's or Regan-Lovey. It is kali khasi, so everything is going to be black, right? Everything is going to be black. Since it is kali khasi, so even the transport media is going to contain charcoal, and even the culture plate is going to look black, which is the Regan-Lovey agar or the Bodegengu agar. ठीक है? So, culture media is a Bodegengu, potato blood agar, BGGB, or Regan-Lovey medium. specifically for Bordetella pertussis. These are dark colored agars on which we see the mercury drops or the dissected pearls. So there goes the mnemonic of asking Gangu to cough on a black agar, and she coughs out pearls. Okay, so dissected pearl appearance. Then you can of course do ELISAs and PCRs, which can be done for every bacteria. For treatment, you can give erythromycin-based prophylaxis to the contacts and vaccines. You have a whole cell vaccine and you have acellular vaccines. Okay, what was done in whole cell vaccines? You would take a totally heat inactivated bacterium and you would give it as a part of the DPT. But it was associated with adverse effects like encephalopathy. This is a very important Viva Voce question which they keep asking. Encephalopathy was the main side effect. So what did we do? We took the pertussis toxoid, FHA and fimbrial antigens. Only the main antigens we have taken, and therefore there is significantly lower side effects. So if you remember the antigens of vaccine, the same antigens you can mention in the virulence factors as well. Okay, so just to give you a mind map. All right. ठीक है. फिर और NLFs भी होते हैं which cause your upper respiratory tract diseases or lower respiratory tract diseases, such as the nosocomial pathogens which are hospital acquired, which are frequently multi-drug resistant, such as your Pseudomonas and Acinetobacter, which love to live in the moist environments, which love to live inside detergents, which love to live inside IV fluids, and they love to form a biofilm. That is why they are the most dangerous. Who are they? They are Pseudomonas and Burkhold and Acinetobacter. Already discussed. Okay. So, what about Pseudomonas aeruginosa? The name itself says aeruginosa. So, this guy is an obligate aerobe, right? Obligate aerobe, which is a green pigment producer. Oxidase positive hai, obligate aerobe hai, right? It is the prototype organism for oxidase positivity. You know it, right? Common causes: swimmer's ear, malignant otitis externa, and contact lens keratitis. You know it. You know all of this. For lab diagnosis, if it is any otitis externa or any pus-producing infection, you collect the pus. If any wound is there, you collect the swabs, or you collect the CSF sputum blood, depending upon what patient is infected with. It grows on basal media, but it produces surface pellicle. Why? Because it's an aerobe. So it comes to the top of the broth just to get the air. So you will see the green pigment production in surface pellicles for Pseudomonas. It produces 4 types of pigments: pyocyanin, which gives it the blue-green color; pyoverdin, which gives it the greenish color; pyorubin, which makes it red; and pyomelanin, which makes it brown or black. So all of these colors of Pseudomonas are very much possible. Then selective media is cetrimide agar, right? So cetrimide is a low-level disinfectant. So something which is used to kill the bacterium actually makes Pseudomonas grow a lot better because it is resistant to cetrimide. So we take an agar and add cetrimide to it so that nothing else can grow, but Pseudomonas can grow beautifully. Okay, so cetrimide agar is the selective media. It is actively motile, and what are the biochemicals? Indole negative, citrate positive, urease negative, catalase positive. So citrate positivity and catalase positivity. So both the C's. So it is CC positive. CC positive. Very unlikely that you will get a short note on Pseudomonas aeruginosa, but you can get a clinical scenario of contact lens keratitis in which you might need to write about Pseudomonas, or you can get a clinical case of a burns patient in that scenario, but a little unlikely for you to get this question. So only the major aspects we have discussed. Then this is a very potential short note, which is melioidosis. Melioidosis is a very potential short note because recently we have seen outbreaks in Tamil Nadu and in many parts of India. Okay, and it's one of the weird organisms which we read. So that can very much come as a short note. So Burkholderia species is again oxidase positive. It has a characteristic safety pin appearance or bipolar staining. What is the mnemonic, guys? My student will know the mnemonic for bipolar staining or safety pin appearance. You see how this bacteria has only taken the stain on the 2 ends. So that is why it's giving me the safety pin appearance. So what is our mnemonic for the bipolar stain or the safety pin appearance? My students can write it in the chat box actually. So the mnemonic is that this can be very high yield for your exams. Can be very high yield. So K for Klebsiella, but not Klebsiella pneumoniae. We have just read Klebsiella pneumoniae and I did not say anything about bipolar staining. So what is it? Klebsiella granulomatis. Granulomatis, which is actually a cause of donovenosis, which is a genital ulcer. Which is a genital ulcer, right? I hope you remember. Then you have B. B for Burkholderia. So this Burkholderia is what we are reading right now. It is causing melioidosis. Then V for Vibrio. Of course, not the common Vibrio, the abnormal. It's an abnormal staining. So all the abnormal bacteria we are going to read. So Vibrio parahemolyticus. Vibrio parahemolyticus. All right. और क्या है आपका हाई ईल्ड सो हीमोफिलस बट आई जस्ट रेड हीमोफिलस इन्फ्लुएंजी नो मेंशन ऑफ बाइपोलर स्टेनिंग सो ऑफ कोर्स नॉट हीमोफिलस इन्फ्लुएंजी बट हीमोफिलस पैरा इन्फ्लुएंजी ओके सॉरी हीमोफिलस ड्यूक्री which causes chancroid, which is again a genital ulcer. And Y for Yersinia pestis. Yersinia pestis, which causes the plague. Okay, so this is done. So we have just seen this guy, Burkholderia. So you have to write about. Your melioidosis in the Burkholderia species. It is intrinsically resistant to polymyxin B or colistin. I always tell you to remember just two guys who are intrinsically resistant to polymyxin B. What is intrinsic resistance? That they were born this way. By birth, they are resistant. So it is not because of multi-drug therapy that they have acquired this resistance. By birth, they have the ability to stay resistant to polymyxin B. So, intrinsic resistance to poly B is shown by two guys whose name itself has P and B. So, what is P? Proteus. Proteus is intrinsically resistant. And what is B? Burkholderia. Burkholderia is intrinsically resistant. So, Proteus and Burkholderia are intrinsically resistant to polymyxin B. And you have three species: Burkholderia pseudomallei, Burkholderia mallei, and Burkholderia cepacia complex. Now, pseudomallei causes melioidosis. Melioidosis is also called as Vietnamese time bomb. Why? Because the disease remains latent for many years and suddenly bursts. Okay, so you will have a prolonged history. So it bursts just like a time bomb, and it is found in the soil, especially in these oriental regions. So that is why Vietnamese time bomb, because of the Vietnamese war. So basically what you have to think of is anything which looks like tuberculosis, but you are not able to prove that it is tuberculosis. The presentation is going to be exactly like TB, but none of the tests for TB will come out to be positive. In that scenario, you should definitely think of Burkholderia pseudomallei or melioidosis, which is Vietnamese time bomb. It is a potential agent for bioterrorism. And when you think of time bomb, you think of a time bomb bursting. So you think of ash everywhere. So what is the agar used? Ash down agar. Then Burkholderia mallei causes glanders in horses. So this is not a human disease. Cepacia complex is a nosocomial pathogen. So Cepacia complex will cause bloodstream infections. Cepacia complex will cause ventilator associated pneumonias. Okay? Then you have Acinetobacter baumannii, which is also gram-negative Coccobacillus. This is also multi-drug resistant. This is also healthcare associated infections. Okay, and it lives as a saprophyte in the hospital surfaces, in the environment, in the water bodies, etc. So very important nosocomial pathogen. So all the weird bacteria is done. Okay, now we move on to viruses. So all possible bacterial agents of lobar pneumonia are covered. But please understand, at university level, they will ask you some common things. So if it's a long question, They want you to pass. So usually for a long clinical case question, they don't give these weird guys. These weird guys, which is Pseudomonas, Burkholderia, Acinetobacter, they all can come as a 3-marker short notes. They will never give you in a long 20-marker question. So what do you need to remember for the long 20-marker? Strep pneumonia and H influenzae. Those are the main two heroes of lobar pneumonia, which they can ask as a long question. Okay. So with that understanding, let's go to the viruses. Like I had said, amongst the Myxoviridae family, you have Orthomyxoviridae and Paramyxoviridae, and Orthomyxoviridae is influenza virus, which has been covered in the last year's FARRE lecture. Today we are covering the other guys, which are the Paramyxoviridae family. The Paramyxoviridae family mostly causes self-limiting upper respiratory tract infections. Okay, two major important viruses involved here are measles and mumps. Measles and mumps. So yesterday we have covered measles. Yesterday in the skin and soft tissue viral exanthems part, we have covered measles. The same thing you need to write even for the respiratory tract if it comes as a short note of Paramyxoviridae. Okay? Mumps is something that we will do now. It is classified into parainfluenza, mumps and measles, respiratory syncytial virus, metapneumovirus and some zoonotic viruses. So how do we remember? My students know the mnemonic. Whenever we talk about paramyxoviruses, we say PMMRM. What do we say? We say PMMRM. Okay. So P stands for parainfluenza virus. Parainfluenza virus. M stands for mumps. This M stands for measles. Then this is not rubella. This is respiratory syncytial virus. And then finally you have the human metapneumovirus. Human metapneumovirus. And then some zoonotic viruses, which are the Nipah and the Hendra. Nipah, Hendra. But Nipah, Hendra don't cause respiratory diseases. Nipah, Hendra cause encephalitis. So these are out of this mnemonic. Why are we reading in this particular order only? Why are we only reading it as PMMRM? Because we need to remember two important antigens. So all your paramyxoviruses, they are close cousins of the influenza virus. So all of them have a single-stranded RNA. Then they have a helical nucleocapsid. On top of this, they have a envelope, right? On top of this envelope, there are two important proteins. One is of course called as the fusion protein. So this fusion protein is definitely going to be there in all of them. It is present in all of them. The other problem is this protein. This protein could be hemagglutinin, could be neuraminidase, could be both. Okay. So that is how we differentiate. Which have, oh, good Rishabh, good to know that. So which have both and which have one and which have none. So you simply write PMMRM, then you write Ha and Na. Ha and Na, HA and NA. So the first two will say Ha Na. What does measles do? Measles is one less. Measles, okay, it is one less. So it says Ha hai and Na nahi hai. Na nahi hai, okay. Ha hai, na nahi hai. So it has HA, it does not have neuraminidase. What about respiratory syncytial virus and human metapneumovirus? Both are not there. Neither neuraminidase nor hemagglutinin. Okay. So depending upon this, you can make the morphology or the structure of any of these viruses. Any of these viruses. Simply a single-stranded RNA, helical symmetry, and an envelope with a fusion protein. Other than that, HA and NA protein will depend upon this table. So now, when we are talking about them, unsegmented single-stranded RNA, then hemagglutinin or neuraminidase present on a single peplomer. So they are present on a single protein, right? Fusion protein is the most critical protein. So you can make single-stranded RNA, make a lipid envelope, make the fusion protein and HA or NA depending upon which species we are dealing with, right? Then when we talk about para-influenza virus, it is responsible for causing croup, which is laryngotracheobronchitis, especially in the children. So it's a major cause of respiratory illness and type 3 is the most common serotype. Okay, there is a metallic loud shrill cough. So it can also be called as barking cough. barking cough, which is called as croup. Most common cause of croup in children is para-influenza virus. Okay, common cold like illness, but croup is the most important thing. What will you do for lab diagnosis? You will collect nasopharyngeal swab or you will collect a BAL. Antigen, PCR, virus isolation. Something which you commonly do for all viruses. Nothing special here. Just write the common things, okay? Then you have the mumps virus. Measles has been done yesterday. Mumps is remaining. So see, mumps causes the disease which also sounds like mumps. So mumps sounds like something big, okay? So there is a big swelling in the parotid gland of the patient. This is parotitis. What is the primary disease of mumps? It is parotitis. Okay. So there is respiratory secretions. They enter your respiratory tract. They replicate in the respiratory tract and the lymphoid tissues. They enter the blood and they disseminate to the organs. In the organs, they then go to pancreas causing pancreatitis, testes causing your orchitis, ovaries causing oophorytis, pancreas causing pancreatitis, brain causing meningitis. Anywhere they can then go inside the body. Okay. So, yeah. So, the first sign is parotitis always, which can be bilateral, and the Stenson's duct can also become swollen and blocked in this case. Complications are orchitis or epididymoorchitis, oophorytis in females, pancreatitis, meningitis, and sensory neural hearing loss can happen. Like I said, right? So it basically causes inflammation of all the ducts, Then what is the sample you collect? A very, very special sample is collected for mumps. So while for all respiratory tract infections, a common sample that you can write is nasopharyngeal swab and bronchoalveolar lavage. Especially for mumps, you have to collect a buccal swab after doing a 30 seconds parotid massage in the patient. So you do a parotid massage in the patient and then you correct a buccal swab, because when you do the parotid massage, the parotid secretions come out, and in those secretions, your mumps virus comes along. Of course, you can detect in the urine, CSF or semen depending upon what it is infecting. If it is causing orchitis or epididymoorchitis, it will come out in the semen. If it is causing meningitis, it will come out in the CSF. If it is causing a disseminated disease, the antigen is going to be shed in the urine. Virus isolation can be done and serology can be done. Okay. Prevention is the MMR vaccine, the measles, mumps and rubella vaccine. You know that it belongs to our mnemonic of Japanese chicken Bombay train. So MMR is measles, mumps, rubella. What is the strain of mumps which is used? It is the Geril-Lin strain for mumps. Geril-Lin strain. All right. Then we have RSV. What is RSV? Name itself says respiratory syncytial virus. Why syncytial? Because it shows me a particular cytopathic effect. Meaning when I take the virus in the lab and I infect some cell lines with this virus, it destroys those cell lines and all of those cells, they coalesce together to form a syncytium. That is the syncytium formation shown by it. It causes nothing. It causes an influenza-like illness in children less than 1 year of age. Okay. You can see pulmonary infiltrate. So, it leads to pneumonias. And R for respiratory syncytial virus, R for ribavirin is the drug of choice for RSV. We will do virus isolation, and on this virus isolation and cell lines, it will show me the cytopathic effect, which is syncytium formation. Syncytium formation. Okay. Of course, you can do ELISA, PCR, and then the human metapneumovirus also causes influenza-like illness. But whenever there is ILI plus rash, then we think of HMP. So, there is ILI plus rash, then we think of HMPV. Okay, nothing special here after that. Now, we're remaining with the parasitic infections. We're done with abnormal bacteria. We're done with some weird viruses. And now we're talking about the parasites. Two major important parasitic diseases of the lungs. The only primary pathogen parasite of the lung is lung fluke. Okay. Others can secondarily involve the lung, such as strongyloids, due to its autoinfection, reverse peristalsis, can come to the lungs, then go back. Okay. Similarly, filarial worms, their antigens as a chronic progression can cause occult pulmonary eosinophilia. But primarily, as a primary site of infection, there is only one parasite, which is lung fluke. Okay. What is lung fluke? It is Paragonimus westermani. So, pulmonary parasitic infections either primarily by the lung fluke or a hypersensitivity response to the antigen, such as in occult filariasis. Okay, so you can see both of these things here. Now, my students will always remember that whenever we read about Paragonimus westermani or lung fluke, we think of a jingle. We think of a jingle of a slipper brand, chappal brand. When I was a kid, there used to be a ad on the TV saying Paragon chappal hawa se halki. Okay, so there was Paragon slippers which were lighter than air. So always remember air and respiratory tract, and remember Paragon slippers. So remember Paragonimus westermani. Who is he? Paragonimus. Okay, Paragonimus westermani. What is it causing? It is causing oriental lung fluke. Why oriental lung fluke? Because that is the part of the world which it affects. So if it's an Indian patient, you will get a history of the Northeast, or you will get history of somebody from Japan, China, Hong Kong, Vietnam, Northeast India, all of these. That is why it is called as oriental lung fluke. Okay, it is found in the eastern countries. Pathogenesis is presence of the parasite in the lung leading to eosinophilic granulomatous inflammation. Whenever there is any parasite in the lung or near about the lung, you see these eosinophils coming out into the sputum. Whether it is Paragonimus, whether it is topical pulmonary eosinophilia or occult filariasis, whether it is strongyloid infection. Eosinophilia is a marker of parasitic involvement. Okay. Yes, westermani in eastern areas. Exactly. That is what is funny. Okay. So it causes endemic hemoptysis. See, look at the words. Endemic hemoptysis. Hemoptysis, why? Because of the parasitic infection of the lungs. So it is leading to blood in the sputum. But why endemic? Because of this oriental. It is only found in the endemic zones. It will usually does not affect other parts of the world. So endemic hemoptysis. In specific areas, people will start coughing out blood. Okay. So hallmark is the cough with foul smelling red brown sputum. Okay. There is red tinge to foul smelling sputum. It is a leaf-like structure. Why? Because all trematodes are called as fluke because they have a leaf-like structure. So you will draw a patti, you will draw a leaf, and all trematodes have operculated or eggs with a lid or dhakkan. Okay. So these eggs with a lid or operculum are your operculated eggs. For lab diagnosis, you will do the eggs, find the eggs in the sputum, guys. Please, while writing fast in the exams, don't write egg in stool because you're so used to writing about egg in stool in parasites, you forget that you're talking about a lung fluke. Where will the eggs of the lung fluke come? They will come in the sputum. They have nothing to do with the feces, okay? They can be detected in the feces under one circumstance. If the person ends up swallowing the sputum, then it can come, but that is not the main diagnostic feature, okay? The main diagnostic feature is you collect the sputum sample of the patient, and in that sputum sample, you're seeing operculated eggs. So, of course, ELISA and Western blot can be done. Right? Now, just to remember everything about trematodes, and same things you can write for Paragonimus as well. My students will always remember that the trematodes have some particular rules. So all trematodes are going to have two intermediate hosts. All right. So the first host in all is always and always snail, and the second host can be fish, cyclops, or freshwater plant. So in case of lung fluke, it is cyclops or oysters, and in case of the names which start with F, Fasciolopsis busci, Fasciola hepatica, which is the intestinal fluke, and liver fluke, it is the fresh aquatic plants. That is the rule of all the trematodes. Then I know as a rule, all trematodes are monoecious. Their sexes are not separate. They are hermaphrodite. All have a leaf-like body. That is why they are called as flukes. All have the mode of infection is ingestion. Okay, we either end up ingesting the fish or the cyclops or the fresh aquatic plants. And what do we ingest along with it? What is the infective stage? The larval stage, Metacercaria larva. Metacercaria larva, right? And all of them have operculated eggs. All of them have operculated eggs. What is an operculated egg? Egg with a lid or operculum on top. ढक्कन. ठीक है? Yes, that is the reason. The food habits is the reason. Shriyakanta Panda. Okay, yes, food habits is the reason. Okay. Now, the larval stages of all trematodes, they go by very many larval stages. So, what will happen? The Metacercaria larva. Metacercaria. Okay, do I have a... Yes, I have this over here. So, let's move it. So, you see the life cycle of Paragonimus. You see that the Metacercaria larva is what is ingested by us by using the cooked or pickled crustaceans. That is why it was being found in that part of the world, right? Where it is a delicacy to eat these items. You ingest the Metacercaria larva along with it. It goes to our duodenum, exists. The worm comes out. The worm or adult sits in the lung cavities and excretes the eggs which are excreted into the sputum. If these eggs are swallowed, then they can be passed in the stool. Okay. So, either from the stool or from the sputum, you are seeing the unembryonated operculated eggs with a dhakkan or lid on top or operculum on top. These eggs will go into the water and in the water they will become embryonated. This is a rule for all trematodes. So if you are writing lung fluke, liver fluke, intestinal fluke, any fluke, eggs are always unembryonated. They go to the water, then they become embryonated. Then what hatches out is Miracidia, which is the first stage of larva. It goes to the first intermediate host, which is the snail. Inside the snail, they convert into sporocyst, rhedia, then cercaria. This cercaria comes out like a freely swimming guy, goes into these crustaceans, turns into metacercaria. Again, they are ingested by us. This is the life cycle of any fluke, be it liver fluke, lung fluke, or anything, intestinal fluke. So how to remember this? Miracidium, sporocyst, rhedia, cercaria, metacercaria. Please draw this life cycle in the exam. You need not draw this human and all these fancy diagrams, but you can at least write the words and make the arrows. Okay. So make this life cycle, because the life cycle of trematodes is the easiest thing in this world, because it is common for all the flukes, right? So how to remember these stages, that is a problem. So there is a mnemonic. So mnemonic is my silly red cat mews. So Miracidium is my, sporocyst is silly, rhedia is red, and cercaria is cat. My silly red cat meows. So metacercaria. That is the mnemonic. My silly red cat meows is the mnemonic to remember all the larval stages of trematodes, no matter which fluke we are talking about. Miracidium, sporocyst, rhedia, cercaria, and metacercaria. Okay, you're welcome, Shriyakanta Panda. I'm so glad that the videos are helping you. Keep learning, keep reading. All the best. Right? Finally, we talk about tropical pulmonary eosinophilia. Now, this is a hypersensitivity reaction, or this is a chronic granulomatous reaction in response to the antigens, not in response to the actual parasite. Who is the parasite involved? It is filaria. This is also called as occult filariasis, and this in itself is a short note. Okay, they will simply give you a short note called as tropical pulmonary eosinophilia, or TPE. So what is TPE? It is also called as occult filariasis. In this, the microfilaria are absent from the peripheral blood. Okay, we keep reading about lymphatic filariasis. Yes, in that there is elephantiasis, and mosquito bite gives the filarial worm. How do we diagnose it? We collect the blood sample at night and we see the microfilaria worms in the peripheral blood smear. What happens in occult? Occult means hidden. So it's a hidden filariasis. I will take the blood sample of the patient. I will not find any microfilaria in the blood. Okay. So what do I need to do? I need to take the sputum sample. what happens here, that the filarial parasites, they have their antigens, typically Wuchereria bancrofti or Brugia malei. Okay. In response to their antigens, there is a hypersensitivity reaction. This hypersensitivity reaction in response to the antigens is what is leading to tropical pulmonary eosinophilia or occult filariasis. Okay? It is also called as Weingarten syndrome. Now guys, I have told you that some of the universities, some of the examiners have gotten into this fancy habit of giving a simple fancy name for a short note. Now that could be because they are making the question papers with the help of AI. So the AI is picking up the fancy names and giving in the form of a short note. Okay. So instead of giving TPE or occult filariasis, the short note can also simply say Weingarten syndrome. Write a short note on Weingarten syndrome. So what is that? Don't fear it. Don't lose hope suddenly. It is nothing but tropical pulmonary eosinophilia. There is marked eosinophilia in the CBC of the patient. There is raised IgE levels, of course, because it's a hypersensitivity reaction. On the chest X-ray, you can see the bilateral infiltrates. You simply give diethyl carbamazine, which is the same drug of choice as filariasis for management of TPE as well. What is the main feature? This line is the main feature of differentiation between the two types of filariasis, right? So this is a pulmonary involvement. What are some other parasites which can involve? So you have primary parasite of lung is lung fluke. Another hypersensitivity reaction to antigen of parasite is occult filariasis. Other parasites which can come as a part of their life cycle but not primarily cause disease of the lungs is Ascaris lumbricoides. You know that the larva or the adult of Ascaris can roam about in the body. It can be cuffed up into the sputum. Hookworms, also the rhabditiform larva, loves to move about causing larva migrants, and Strongyloids turcularis. So all the agents of visceral larva migrants. Who all cause visceral larva migrants? You have strongyloids and Toxocara canis. They both can lead to, for a brief period, appearance in the sputum or the respiratory tract also. So you should be able to draw this differences table between classical and occult filariasis in case you get a short note on TPE. Okay, please draw this differences table. Only this will fetch you good marks. Right? So what will you write? You will write about microfilaria. You will write what is the primary site of infection in this disease. You will write what are the key lab findings, and you will write what are the clinical presentations. So microfilaria will be present in classic filariasis, but that is going to be absent from peripheral blood in the occult filariasis. Okay. The primary site is lymphatics. That is where it was blocking and leading to elephantiasis. Here it is lungs because of the hypersensitivity reaction to the antigens. Key lab finding is the microfilaria detection in peripheral blood smear. Over here it is the massive eosinophilia and high IgE counts, but no microfilaria found in the blood. Clinical presentation over here is elephantiasis and lymphangitis, and over here it is respiratory distress and Weingarten syndrome. All right. So your homework is to go and watch this lecture, because you're going to find tuberculosis, non-tubercular mycobacteria, aspergillosis, zygomycetes, influenza, atypical pneumonia, Epstein-Barr virus, so many topics, strep pneumonia, diphtheria. All the topics have been covered in this lecture, and all the weird extra topics which get asked as a short note, which we always tend to ignore and lose marks on, those have been covered in today's lecture. After watching these two lectures, respiratory tract is complete in full total all respects. Nothing gets left behind. Okay, so just watch these two lectures, spend 3 hours, watch it at 2x, spend 1.5 hours, and your entire unit gets covered. All right guys, so thank you so much for attending, and thank you so much for all this beautiful special compliments in the chat box. Of course, all of the videos are meant to make your life a little bit easier and to make microbiology interesting for you. So thank you so much. Yes, you can use this series. Definitely, you can use this series. All right. So thank you so much, guys. Good night. I will see you soon. बिल्कुल देख सकता है FMG student if they want to gain a better understanding. However, there are different videos available for the FMGs in which we focus more on the MCQs. All right. Bye bye, guys. Bye, Aishi. Very nice to see you. All right, guys. Good night. I will see you soon. Bye bye.